Welcome to the audio digest of the American Journal of Psychiatry. I'm Michael Roy with highlights for the month of March 2007. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosure statements. This month, we'll look at schizophrenia from various perspectives, from neurophysiology to functional treatment outcomes. We'll begin with a report from the Katie Project by Scott Stroop and colleagues, who discuss the effectiveness of Olanzapine, Quetiapine, and Risperidone in patients with chronic schizophrenia after discontinuing profenazine. We'll also present a related editorial by Stephen Martyr. One of the articles on psychosocial outcomes is also from the Katie Project. Marvin Swartz and colleagues discussed the effects of antipsychotic medications on psychosocial functioning in patients with chronic schizophrenia. We'll follow this with an article by Susan McGurk and colleagues, Cognitive Training for Supported Employment, 2 to 3 year outcomes of a randomized controlled trial. The journal this month also contains several reports on the relationship between particular types of brain dysfunction and specific cognitive deficits in schizophrenia. These are discussed in an editorial by the journal's editor-in-chief, Robert Friedman. We'll conclude with our Treatment in Psychiatry feature, Schizophrenia and Co-occurring Substance Use Disorder, by Alan Green and colleagues. Let's begin with the article by Scott Stroop and colleagues, Effectiveness of Olanzapine, Quetiapine, and Risperidone in Patients with Chronic Schizophrenia After Discontinuing Profenazine, a Katie study. Katie, the Clinical Antipsychotic Trials of Intervention Effectiveness, was designed to compare antipsychotic drugs under conditions resembling those of clinical practice. The time to discontinuation of each study drug was chosen as the outcome measure. Phase 1 of Katie included a first-generation antipsychotic drug, profenazine. Of the patients randomly assigned to profenazine, 114 stopped taking it during the 18-month trial and were then randomly assigned to a second-generation antipsychotic in Phase 1b. The mean time to discontinuation of the second drug was 10 months for Quetiapine, 7 months for Olanzapine, and 4 months for Risperidone. However, the 3 treatment groups did not differ significantly in the time to discontinuation based on either efficacy or tolerability. The only adverse medical events for which rates differed among the 3 treatment groups were weight gain and increases in total cholesterol and triglyceride levels, which were greatest for Olanzapine. A weight gain of more than 7% of baseline body weight occurred in 36% of the patients taking Olanzapine, 24% of the Quetiapine group, and 14% of the Risperidone group. The inability to tolerate the medication was also examined within the patients who had stopped taking profenazine in Phase 1 because of intolerability. In Phase 1b, no patients discontinued Quetiapine for this reason, whereas more than 60% of the Olanzapine and Risperidone groups discontinued treatment because of adverse effects. The outcomes for the 3 second-generation antipsychotics are somewhat different from those in Katie Phase 1 and Phase 2. The subjects appeared to respond best to Olanzapine and Quetiapine, the study medications that differ most from profenazine, and they responded less well to the more similar drug, Risperidone. Dr. Stephen Martyr discusses these results in an editorial, Lessons from Each Drug Trial. He states that the surprising finding from the Stroop article is that the relative effectiveness of the 3 drugs differed substantially from that in Phase 1. A defining characteristic of this study group may be their sensitivity to the side effects of profenazine. For example, among the patients who stopped taking profenazine because of extrapyramidal side effects, 5 of 6 also discontinued Risperidone. Patients who experience extrapyramidal symptoms while taking profenazine may represent a group of individuals with a greater sensitivity to the side effect, and these individuals will experience varying amounts of extrapyramidal symptoms while taking Risperidone. In a similar vein, this group of individuals may do well with Quetiapine, an antipsychotic with minimal extrapyramidal side effects. However, there were no differences among the 3 newer antipsychotics in the scores on rating scales for extrapyramidal side effects, akathisia, or tardive dyskinesia. This inconsistency may tell us something about mild extrapyramidal symptoms and how difficult they can be to detect. The observations of expert clinicians nearly 30 years ago may be useful to today's prescribers. At that time, there was a concern that many clinicians were failing to appreciate that milder forms of akathisia and akinesia can be confused with depression and anxiety. Individuals with subjective akathisia may describe themselves as feeling anxious, uncomfortable, or irritable. These patients often do not demonstrate restless movements. Even a mild internal feeling of restlessness can be tormenting if a person experiences it all day. Mild Parkinsonism can also be difficult to detect. Experienced clinicians learned that they could detect mild rigidity by looking for a decrease in normal arm swing or a lack of expressive gestures. Individuals with mild Parkinsonism may also feel slower. These vague symptoms could explain the differences among the drugs reported in the Stroop article. Mild extrapyramidal side effects may be embedded in the 32% of the Risperidone patients whose discontinuation was classified as patient decision. These may have been individuals who disliked their drug but were unable to give an explanation that could be categorized as a side effect. These speculations about mild extrapyramidal side effects as an explanation for the differences among these drugs are only weakly supported by the study data. Nevertheless, they suggest an important principle for treating schizophrenia. Finding an antipsychotic regimen that patients can live with comfortably is an essential part of an effective management strategy. Each antipsychotic trial provides an opportunity to understand the factors, particularly the side effect sensitivity, that may affect how a patient feels while taking the next drug. This concludes the highlights of the editorial by Stephen Martyr. Please refer to the March issue for the full editorial and the Stroop article. Now we'll turn to functional outcomes for patients with schizophrenia. We'll begin with an article by Marvin Swartz and colleagues, Effects of Antipsychotic Medications on Psychosocial Functioning in Patients with Chronic Schizophrenia, Findings from the NIMH CATIE study. The primary outcome measure in the CATIE project was the time until discontinuation of the study drug. However, the return of daily living skills is a practical measure of success in the treatment of serious mental illness. The Swartz article reports on the psychosocial functioning of patients over the first 12 months of the CATIE investigation. Outcomes were compared for patients taking 5 different antipsychotics: profenazine, olanzapine, quetiapine, risperidone, and clozapine. Profenazine is a first-generation antipsychotic. The others are newer, atypical antipsychotics. Clozapine was included only in the second random assignment for patients who had discontinued the first drug because of a lack of efficacy. Improvement in psychosocial functioning was measured with the Quality of Life Scale, which was administered to the patients at baseline and at 12 months. The ratings are made by a clinician, and separate scores are determined for social functioning, interpersonal relationships, vocational functioning, and psychological well-being. 400 patients remained in the study at 12 months and had ratings both at baseline and 12 months. Several of the drugs produced modest improvements in psychosocial functioning, but the drugs did not differ significantly from each other on these ratings. An important limitation of these findings is the large number of patients who discontinued treatment early and were not included in this comparison. The patients who dropped out were younger, had more severe symptoms, and were more likely to have substance use disorders. In addition, there appeared to be a ceiling effect. The 40% of patients who had relatively good functioning at baseline made no gains. More intensive psychosocial rehabilitation, including cognitive rehabilitation, may be needed to improve their outcomes. The focus of Susan McGurk and colleagues was an intervention to improve employment outcomes for patients in supported employment. The results are described in the article, Cognitive Training for Supported Employment, 2 to 3 year outcomes of a randomized controlled trial. Supported employment is a job in the community done by a worker with a disability who needs assistance to learn job requirements or adapt to a competitive employment setting. It has been repeatedly demonstrated to improve competitive work outcomes in people with severe mental illnesses, but not all who participate in the program benefit from it. Cognitive functioning is a potent clinical predictor of response to a variety of interventions for psychiatric rehabilitation. The McGurk article describes the results of a controlled evaluation of a cognitive training program for supported employment. In this program, cognitive training is provided by a specialist who collaborates with the supported employment specialist to provide cognitive remediation and to develop compensatory strategies for cognitive impairments that interfere with work functioning. The program includes 4 components. The first is cognitive assessment an analysis of how cognitive problems have interfered with past job performance. The second element is computer-based cognitive training sessions for 12 weeks. The third step is review and discussion of the gains made after cognitive training, as well as collaborative planning with the patient and employment specialist about preferred jobs and coping strategies. The final element is ongoing consultation between the employment specialist and the patient to develop additional compensatory strategies for any cognitive impairments that interfere with job performance. 23 patients were randomly assigned to supported employment plus cognitive training, and 21 were assigned to supported employment only. Outcomes were measured after 2 to 3 years. The combined program produced significantly better employment outcomes in terms of number of jobs, number of hours worked, and amount of wages. The average total number of weeks worked over the 3-year follow-up period was 27 for the combined program, but just 5 for the participants who received supported employment only. The patients in the combined program also showed significant improvements in depression over the 3 months of the cognitive training period. This suggests that the impact of the program is not limited to cognitive functioning. Next, we'll highlight 6 articles that link malfunctions in the brain to deviant cognitive processes in schizophrenia that could cause the patient's thinking to lose its grasp of reality. Robert Friedman discusses these articles in an editorial, Neuronal Dysfunction and Schizophrenia Symptoms. Each of the 6 articles considers a physiological deficit in the brain revealed by an imaging technique and attempts to link it to cognitive and clinical symptoms. None of the articles, separately or together, give us the all-encompassing picture of schizophrenia that we seek, but each tells us something about how a part of the brain functions abnormally and what the psychological consequence of the malfunction appears to be. Persons with schizophrenia often cannot automatically discriminate important from unimportant information. Raquel Gurr and colleagues tested whether the problem is the patient's inability to focus or whether it is their inability to filter out responses to distracting stimuli. The results are presented in the article Visual Attention Circuitry in Schizophrenia, investigated with oddball event-related functional magnetic resonance imaging. The subjects watched a screen for target symbols. They were instructed to push a button each time they spotted a target. Intermittent distracting pictures were also presented. The investigators found that patients with schizophrenia had less blood flow than comparison subjects in the frontal cortex and basal ganglia in response to the target stimuli. This evidence indicates that in schizophrenia, the brain is not as active in selecting stimuli in the frontal cortex for responses programmed by the basal ganglia. However, the distractor stimuli overactivated the blood flow in the inferior parietal lobe, indicating that neurons there were not as able to discriminate the distractors from the more important target stimuli. Thus, persons with schizophrenia have both problems in information processing. The brain idles in a default mode in which there is interconnected processing of activity among major centers in the cerebral cortex. Abigail Garrity and colleagues studied this default activity with auditory stimuli, both targets and distractors. Their article is titled Aberrant Default Mode Functional Connectivity in Schizophrenia. They studied the activity of an interconnected network that includes the frontal, cingulate, parietal, and parahippocampal cortices. Blood flow was measured with functional magnetic resonance imaging. In normal comparison subjects, the network resonated slowly and regularly, but in patients with schizophrenia, the activity was increased and more irregular, and it also correlated with positive symptoms. Thus, in schizophrenia, the brain appears to be hyperactive within some portions and hypoactive in some parts, but the entire circuit is unable to stabilize itself in the default mode. Fabio Ferrarelli and colleagues examined spontaneous brain activity when schizophrenia patients were asleep, thereby avoiding issues of reduced motivation and increased distractibility. Brain activity was measured by using a 256-channel EEG system. Their article, Reduced Sleep Spindle Activity in Schizophrenia Patients, reports a specific deficit in sleep spindles, waxing and waning oscillations at around 12 to 15 cycles per second that occur over the central and parietal brain areas. Sleep spindles are generated by the thalamic reticular nucleus, a thin sheet of inhibitory neurons interposed between the thalamus and the cortex that would appear to be hypoactive in schizophrenia, even during sleep. Dysfunction of this nucleus has implication for the waking state, when it plays an important role in sensory gating and attentional modulation, functions that are impaired in schizophrenia. Inhibition is also the theme of the article by Judith Ford and colleagues, Think Before You Speak, auditory hallucinations in schizophrenia. Brain electrical activity was measured before and during speech in patients with schizophrenia and in healthy comparison subjects. In the healthy subjects, activity in the cortex became highly synchronized about 150 milliseconds before the subject said, "ah." The "ah" itself resulted in activity measured as the N1 wave of an auditory evoked potential. If the "ah" was generated by the subject's speech, then the N1 was reduced. The authors suggest that the preparation for speech activates inhibitory neurons in the cerebral cortex. The diminished N1 demonstrates that the activity of the cortex is inhibited, and this inhibition helps normal persons distinguish their own speech from that of others. This system was dysfunctional in the patients with schizophrenia, who did not experience pre-speech synchronization or N1 inhibition. This malfunction may result in the inability of persons with schizophrenia to distinguish their speech from that of others. In a study of anatomical connections, Sukhwinder Shergill and colleagues used diffusion tensor imaging, a magnetic resonance technique that assesses the alignment of water molecules in myelin fiber paths. This alignment is called fractional anisopatry. Their article is entitled "A Diffusion Tensor Imaging Study of Fasciculi in Schizophrenia." It reports on the integrity of the major white matter fasciculi connecting the frontal and the temporal parietal cortices, and the integrity of the corpus callosum in patients with schizophrenia. One finding was an overall decrease in schizophrenia, compared to normal subjects, of the myelin pathway between Broca's motor speech area in the frontal lobe and Wernicke's receptive speech area in the temporal lobe. Within the schizophrenia group, however, the pathway was closest to normal in the patients who had active auditory hallucinations. David Liepman and colleagues also used diffusion tensor imaging to evaluate connections between brain regions, in this case, to determine why patients with schizophrenia have difficulty in evaluating other people's emotions based on the rhythm and tone of speech, termed prosody. Their results are reported in The Neural Substrates of Impaired Prosodic Detection in Schizophrenia and its Sensorial Antecedents. The patients showed deficits not only in differentiating emotions, such as happiness versus sadness, but also in determining whether a common tune was played correctly or with altered notes. An inability to detect both emotions and incorrect tunes was related to a decrease in the integrity in the connections to the auditory cortex. This relationship indicates that the same types of disconnections that occur elsewhere in the brain occur also within simple sensory systems. In a follow-up study, Liepman and colleagues found that patients also had difficulty in differentiating questions versus statements based on the tone of voice alone. This suggests that deficits in the ability to detect prosody may interfere generally with patients' ability to interact socially. Bleuler was among the first to point out that persons with schizophrenia are unusually aware of stimuli in their surroundings, which he ascribed to failure in an unknown inhibitory brain mechanism. 3 of the preceding studies reaffirmed Bleuler's initial observation that deficits in schizophrenia include problems in processing stimuli at the most basic levels. The failure to inhibit activation by distractors in the GUR study, the failure to maintain stable default processing in the Garrity study, and the failure of the inhibitory thalamic reticular nucleus to function even during sleep in the Ferrarelli study. When we consider more complex psychological processes, discerning internal from external speech, as in the Ford study, the same sorts of elementary inhibitory processes seem to be involved. The conclusion is similar when based on changes in blood flow measured with fMRI or based on EEG analysis, which has recently been enhanced by dense multiple-channel recording and new analytic techniques. Blood flow in the brain changes very precisely in time and space in relation to neuronal activity. The magnetic resonance imager measures the new inflow of oxygenated hemoglobin by the change in the quantum state of the iron molecule inside the heme moiety. The 2 fMRI studies used a signal detection task that originally demonstrated abnormalities in schizophrenia over 30 years ago. The fMRI technique confirms that there is an abnormality in brain function elicited by the task, and shows that it is a complex abnormality involving aberrant activation and inhibition in many brain regions. 2 studies used the magnetic resonance imager in the diffusion tensor imaging mode to look at myelin integrity. The finding of alteration in white matter complements earlier findings of reduced gray matter in schizophrenia. The finding by Shergill that temporofrontal pathways are relatively preserved in patients with auditory hallucinations is evidence that the strengths left to persons with schizophrenia sometimes exacerbate the signs of their illness. More intelligent patients have long been known to have more difficult and persistent paranoia. Here, a more intact auditory system ends up to be the substrate of increased auditory hallucinations. The Leitman study examined a wide range of abnormalities, from executive function to tone detection, and found that all of them were correlated with white matter problems in their appropriate areas, from the primary auditory cortex to the prefrontal lobes. Thus, different psychological abnormalities may have a similar type of tissue pathology, with the difference in psychological outcome simply reflecting the area of the brain involved. The parsing of schizophrenia neuropsychologically then becomes similar to the neurologist's evaluation of a stroke. The vascular process is the same, but the consequence to the patient depends on which brain region is infarcted. This concludes the highlights of the editorial by Robert Friedman. Please refer to the March issue for the full editorial and the articles it covers. We'll conclude with our Treatment in Psychiatry feature, Schizophrenia and Co-occurring Substance Use Disorder, by Alan Green and colleagues. It begins with a hypothetical case report. A 29-year-old Caucasian man was brought to the emergency department by the police after he was found wandering barefoot through the snow. Passers-by had reported that the man seemed intoxicated and was acting strangely. When an officer approached the man, he became belligerent and agitated. The psychiatrist who interviewed him noted a strong smell of alcohol and signs of psychosis. The man clearly demonstrated a thought disorder, and he appeared to be responding to internal voices. Cannabis was detected in his urine by a dipstick test, and an alcohol breath test was positive. As far as could be determined, the man had been receiving treatment at a local mental health center, but he had stopped taking his medication, Risperidone, 4 weeks earlier. During this period, he had been essentially homeless. The literature suggests that nearly 50% of patients with schizophrenia have a co-occurring substance use disorder, most frequently alcohol and/or cannabis. A number of theories have been advanced to explain this high rate. One suggests that a neurobiological vulnerability interacts with environmental stressors such as substance use to precipitate the onset of schizophrenia or relapse. Another model holds that people with schizophrenia have a greater likelihood of substance abuse because of the accumulation of environmental risk factors. Self-medication has also been proposed. Another hypothesis focuses on dysfunction of the brain's reward circuitry. The brain areas thought to be dysfunctional in schizophrenia are part of the brain's reward network, which may be modulated by substance use. Co-occurring substance use disorders are often underdetected and undertreated in mental health settings. Traditionally, substance use and mental health services have been separated. Clinicians must keep possible substance use clearly in mind when evaluating and treating patients with schizophrenia. More than 50 controlled studies have established the importance of integrating the treatment of patients with co-occurring disorders. Programs that coordinate pharmacotherapy, psychosocial treatments, and substance abuse counseling into a single comprehensive package are most likely to have good treatment outcomes. While some controversy exists on the optimal antipsychotic medication for patients with schizophrenia, there is a general consensus that the first-generation antipsychotics are not particularly helpful in the treatment of patients with schizophrenia and substance use disorder. Nevertheless, long-acting, injectable conventional antipsychotics have often been used to avoid the problem of poor treatment adherence. Data on the efficacy of these medications are sparse, however. A number of preliminary studies suggest that some of the second-generation agents may be helpful. A substantial portion of the data on atypicals concerns Clozapine, but none of the studies was a randomized controlled trial. Various medications have been tried as adjunctive treatments for substance use disorders. Disulfiram and naltrexone have been used to treat alcoholism. Although the use of disulfiram for patients with schizophrenia has been limited, the existing data do not indicate liver toxicity or a worsening of psychosis. Naltrexone has shown promise, but needs further study. The co-occurrence of substance use disorder substantially worsens the course of schizophrenia by destabilizing the illness, impeding treatment adherence, and adding the problems of psychosocial instability, legal entanglements, and medical illnesses to the challenge of managing psychotic symptoms. Although the patient described in the preceding vignette was homeless, psychotic, and intoxicated, clinicians should be optimistic about the potential for effective treatment of his co-occurring conditions. While he is in the hospital, clinicians should conduct a non-judgmental assessment that includes contacting the outpatient treatment team and family or support persons for information. Psychiatric stabilization with medication should be initiated immediately. The patient should be offered a choice of antipsychotic medications least likely to exacerbate substance use and most likely to enhance adherence. Since this patient is likely to have a very brief hospital stay, a community-based clinical approach that presents treatment in stages would be optimal. Outpatient clinicians treating a patient who has recently suffered a significant relapse, as this patient has, should reach out to him while he is in the hospital and immediately after discharge to offer practical assistance, such as help with regaining housing and re-accessing entitlements. Once the patient becomes re-engaged in treatment, clinicians can provide counseling to enhance his motivation to participate in treatment and to consider the impact of alcohol use on his ability to attain his own personal goals. Efforts to stabilize the patient's psychiatric symptoms should continue. Ensuring that he continues to take his antipsychotic medication and engaging him in rehabilitation are often addressed first. As the patient becomes motivated to address his substance use, he should be encouraged to participate in a dual disorder treatment group or a contingency management program, since these have the strongest evidence of efficacy. The treatment team should encourage the patient to develop friendships with sober peers and to become involved in activities with substantial reinforcement value that are alternatives to substance use, such as work, exercise, or a hobby. Use of an adjunctive medication aimed at decreasing substance use, such as naltrexone, should also be considered. Once remission is attained, clinicians should focus on maintaining remission over the long term while they address other key issues, such as overall physical health, employment, and ongoing symptom management. This concludes the audio highlights of the March issue of the American Journal of Psychiatry. We invite you to refer to the online issue at ajp.psychiatryonline.org for the full text of these and other articles. Thank you.